Hi folks, Navid here from Edinburgh Endodontist. Today we are covering the next type of luxation injury, the lateral luxation. Lateral luxation is the displacement of a tooth in either a platal or a lingual direction and is almost always associated with a dentoalveolar fracture. You recall our talk on alveolar fractures a couple of weeks ago. This is very similar to that type of injury. One main difference is that in alveolar fracture, you'll see the entire segment of a few teeth moving back and forth. And with lateral luxation, it is one tooth. So it's a diagnosis for one tooth. Obviously, you may have several teeth with lateral luxation next door to each other, okay? But the main difference with alveolar fracture and this type of injury is that with alveolar fracture, you get hold of one tooth, move it, and see the entire segment moving together, okay? But then otherwise pretty much the same thing. So in alveolar fracture, you can have teeth with lateral luxation in the segment, and in lateral luxation, you are very likely to have alveolar fracture. Clinically, the patient may be unable to bite if the tooth is pushed platally. The crown is displaced and the root is displaced in the opposite direction, as you can see in this slide. And the tooth is typically locked into position. So it's not wobbly, it's not mobile. And this is the main difference between, for example, extrusions, where you see the tooth out of the socket, causing interference with the bite, and lateral luxation. So lateral luxation, typically, the tooth is locked in position. So it is not mobile. Radiographically, you'll see the tooth displacement and socket outline, and then the PDL space widening. But then in some areas, you see the PDL space completely disappearing. But generally speaking, taking the normal radiograph may be very difficult, the periapical, because of the displacement of the tooth. And occlusals are generally speaking easier. And as per angulation, in some parts, as I said, you may not see the PDL, but just be aware of this. As explained before, due to alveolar fracture, the apex may get locked in. So if the tooth is mobile, it's probably extruded and is not, lateral luxation. So if it is wobbly, it's not lateral luxation. If it is locked, it is lateral luxation or alveolar fracture. And you need to know this to be able to reposition the tooth, because if it is just mobile and extruded, you need a bit of watch winding axial movement to put it back in. If it is locked, you need axial pressure away and outside of the socket first to disengage and unlock the apex before moving it back into the socket. To manage in primary teeth, if there's no interference with the bite, just leave and monitor. It will hopefully, come back into position. If mild interference is present, just grind the tooth slightly and reassure. But if you've got significant and severe occlusal interference, either extract or try to reposition, taking into account, as we discussed yesterday, the direction of the displacement and the position of the permanent tooth. In permanent teeth, just reposition the tooth. Hold it with a gauze, because if you're unlocking, you want to be careful. The tooth does not actually pop out of the socket altogether. And move axially outside towards the, away from the socket first to unlock the apex first, and then move into the position into the socket. Check the video clip on the clinical repositioning of these teeth that have undergone, lateral luxation on Dental Trauma UK website, and then you will appreciate how the repositioning is done. After repositioning, check the occlusion, see if the back teeth meet, provide a temporary splint, take a check X-ray to ensure the position is correct, and if that's all okay, provide a flexible splint for 4 weeks. Advise on soft diet and normal brushing, and advise the patient to use diluted chlorhexidine, sort of 50-50 with water, and especially if you've got soft tissue lacerations. Monitor the pulp health on follow-up for your baseline and up to 5 years. Also, as we previously mentioned, reassure the patient and parent on the discoloration up to 3 months. And please do not start root canal treatment unless you have 2 clear-cut signs of an infected necrotic pulp. The splinting guidelines that we discussed are similar to what we've already talked about, flexible for 4 weeks in this sort of situation. Use one uninjured tooth on either side and only splint after you take your check X-ray. If the position is incorrect, go back, reposition. Watch the splinting video on Dental Trauma UK website as well if you haven't done so already. Just a case here, you can see the central incisor displaced palatally. It's not the best periapical, but given the displacement, you can accept that. And then you can see it's repositioned with a flexible splint across there. To monitor, see the patient in 4 weeks to remove the splint, 3 months, 6 months, 12 months, and yearly afterwards for 5 years. I personally like to, see the patients to reassure them, at the beginning, maybe in a week, in a couple of weeks to do the pulp test, and to reassure them, and then 4 weeks, 3 months, 6 months, and then on. So I personally like to see them a bit more towards the beginning, just for reassurance. To sum up, no splinting in concussions, 2 weeks in subluxation if tender, 2 weeks in extrusions, and 4 weeks in lateral luxations. And you need to make sure that they're all flexible splint. So far, the only rigid splint we talked about was for cervical root fractures, okay? Everything else is flexible, okay? Okay, so that's it. That's all you need to know about lateral luxations. Tomorrow we will talk about intrusions. Hope this short clip has been helpful. Please watch the video clips on Dental Trauma UK website and come back tomorrow for the intrusions. Stay safe, take care, and goodbye.